Now this is a typically DEXA machine. Obviously it's not available there in every area, so there is a lack of there, but still what are the, if there is a DEXA, if we have, so how we can go ahead with that. So a simple thing, a patient come to us, the clinical risk factors are there, we need to advise DEXA sites. Commonly we advise two sites, lumbar spine and femoral neck. Lumbar spine we see for trabecular bone, and femoral bone is a mixture of a trabecular and a cortical bone. Distal 1/3 radius we don't do for routine patients like postmenopausal or diabetes patients, but if the patient is very obese, typically in diabetes we can see, obviously the positioning in the DEXA machine that not be possible, so we can advise for distal 1/3 of the radius. Now what are the evidences which we have that in diabetes is bone mineral density is reduced or not? I will not bombard with much of the studies, but just Indian context I would like to share. So this was one of our study. I did my DM from AIIMS Jodhpur. So we did a study in type 1 diabetes and see bone mineral density as well as trabecular bone score. I just come what is trabecular bone score. So what we found, all sites BMD were less in type 1 diabetes compared to age, sex and BMI matched controls. Another similar Indian study published by Akhila Bhandarkar ma'am recently in IGM, which shows not in all sites there is difference. So actually what we can get in type 1 diabetes from Indian context, the evidences are not very consistent. We got it definitely less, but not in case of Dr. Akhila ma'am's paper. Now talking about type 2 diabetes, the type 2 diabetes, there lies the BMD paradox. I have already told earlier that the type 2 diabetes can have normal, can have lower, can have higher BMD, but their fracture risks are high. There is no doubt about that. So there are a lot of studies, lot of meta-analysis. I have just taken the latest meta-analysis in 2024, which shows in lumbar spine and femoral neck, there is lower bone mineral density compared to the healthy age and sex matched controls. But the important thing in diabetes, we would advise for a DEXA to look for the bone mineral density. But interestingly, bone mineral density doesn't tell you the complete story. Just look at this case, two separate patients, similar BMD as 0.972 and 0.969. This is an absolute value. But if we see the bone microarchitecture, the upper panel shows a well-structured trabecular bone, but the lower panel shows an altered trabecular bone. So there comes the concept of trabecular bone score, which we can say significantly the lower panel have reduced trabecular bone score. So what is trabecular bone score? So it assesses the texture of the spine using the same DEXA scans, which correlates with the bony microarchitecture, which actually correlates or which signifies the pixel gray level variation in the lumbar spine DEXA images, and it can be get in the same DEXA setting as well. The DEXA machine, the hologic machines mostly, they need to have this software. And very importantly, it's a surrogate marker for bone histomorphometry. And if the patient is found to have lower trabecular bone score, they are having thinner trabeculae, reduced trabecular lumbar and low connectivity density. So talking about trabecular bone score study, there is one meta-analysis published from India by Saptarshi sir and Lakshmi ma'am team. So they have included 6 studies in this meta-analysis. They have found the BMD was not significantly different between type 1 diabetes and controls, but TBS was significantly reduced in type 1 diabetes compared to the healthy controls. So that we need to remember, lower trabecular bone score independently increases the fracture risk. But again, which I have already highlighted, is the DEXA adequate in India? Actually not. Compared to the developed countries, the availability of DEXA is far lower in India, obviously because of its cost. And so to bypass DEXA, can we bypass DEXA and get a fracture risk there? So we have a FRAX tool. So FRAX tool is basically combining the various clinical risk factors. I'll come to what are the components. But the problem is that having all those components, it still underestimates the risk of type 2 diabetes. So this is an online fracture risk calculation tool. These are the various components. You can just type FRAX tool India. It will come like that. So you just need to pull all these values like previous fracture, parent fractured hip. smoker, glucocorticoid intake, rheumatoid arthritis, or any secondary osteoporosis. But the interesting thing that ultimately we will get a 10-year probability fracture of major osteoporotic and hip. But for the diabetes, it actually not calculated properly, kind of under calculate or give us a lower risk of fracture, a falsely lower risk of fracture. So there are some adjustment to the FRAX tool has been suggested. So what we can do, we can increase the age 10 years. So whatever the age of the patient, if it's a 55-year-old, we can keep it at 65. We will write there at 65. We'll tick mark the rheumatoid arthritis. And if we have the BMDs there, we can, in the T-score, we can reduce 0.5 to it. But otherwise, to make it very simple, we have a FRAX Plus. So this is a FRAX Plus. This is also available in online. So we can adjust the probability by using the FRAX Plus in the online software to have an exact fracture risk in case of diabetes. Now about the management part in diabetes. So a patient comes to us, a diabetic patient poorly controlled with a poor bone mineral density or osteoporosis. So obviously we'll talk about the anti-osteoporotic therapy, but very important, which are the drugs, anti-diabetic drugs, which can affect the bone mineral density. Very importantly, this list actually is not that simple, which I have mentioned, but at least 1 or 2 points I would like to highlight. Obviously, the thiazolidinediones, the pioglitazone, having a negative effect on the bone and increases the fracture risk, especially in the postmenopausal women. So that needs to be avoided. This is the one point which I like to highlight. Very interestingly, insulin increases the effect, it increases the bone mineral density, but simultaneously it is showing increased fracture incidence. So that is a very interesting scenario where using insulin can increase the risk of hypoglycemia and can increase the risk of frequent falls, and by in turn the fracture incidence can rise. So that is one of the things we need to remember. Most of the drugs are kind of a neutral effect on the bone mineral density and the fracture incidence. Just I think insulin and thiazolidinediones we need to remember. Now about the various osteoporosis medications which we use in type 2 diabetes, we need to remember. So we mostly have an idea that anti-resorptives like bisphosphonates and denosumab are the commonest anti-osteoporotic therapies, and along with that anabolic therapy like teriparatide, which is a PTH analogs, which we can use. So among them, any drug which can fare better in diabetes? Actually not. So this is one of a study published in 2023 which shows both anti-resorptive and anabolic shown a similar effectiveness in increasing BMD and reducing fractures when patients with or without type 2 diabetes. Now a very interesting thing, that can any anti-osteoporotic regimen actually decrease the incidence of diabetes or can help us to control the glycemic level? So there comes a very interesting findings published in 2023, and there were some subsequent papers as well. So they evaluated denosumab and bisphosphonate and see the incidence of type 2 diabetes there. So there was around 4,000 patients of denosumab and compared with around 21,000 patients of oral bisphosphonate and followed for 2 years. Very interestingly, they showed the incidence rate of type 2 diabetes in denosumab was lesser, significantly lesser compared to oral bisphosphonate. So they concluded that denosumab perhaps can be associated with a reduced risk of type 2 diabetes. Why? There are some mechanisms proposed that the rank, which is a monoclonal antibody which inhibits the rank and rankel interactions, the denosumab. So they are actually a pro-inflammatory master switch. So when we inhibit this rankel, it improves the insulin resistance and also it can stimulate the beta cell proliferation. So that's a very interesting finding, not very much validated, but can be helpful when we are treating such patients with diabetes. So last, about the guidelines AD which I have highlighted in 2025. So in patients which I have already highlighted the age group according to the ISBMR guidelines, the fracture risk need to be assessed in older adults as a part of a routine care in diabetes clinical practice. I know it's very difficult for us, but how we can do as much as possible, and we should prioritize the medications with proven safety profile for bones, and we need to be careful during choosing those drugs which have an elevated risk of fractures. And very importantly, we should avoid the hypoglycemia to avoid the falls and subsequent fractures. Among the anti-osteoporotic drugs, there is not much of a difference. So we can use whatever according to the osteo-BMD levels or whatever the patient's scenario. So between antidisruptives and osteoanabolic. But obviously, we need to optimize calcium and vitamin D in all such patients. So I'd like to end here. Thank you for your kind listening. Also like to thank Lakshmi ma'am for her inputs, because it's kind of our common presentations we have made by own. So thank you very much. Thank you.